Yeah, welcome once again for this INForm meeting, August 23. And this time we have an area which we have not witnessed or heard. So that is translumbar puncture of the IVC. And as such, people have been, um, we were wary of venous accesses for a long time. But now we know that it is unescapable, and it gives a lot of lending hands before your AVF is ready, or in people who where AVF cannot be done and as a bridging access. So we have come to stay, and now slowly nephrologists, including younger colleagues, have become very good in putting in tunnel catheters in the jugulars, and from right jugular to even now left jugular, people are comfortable using the glide path catheters. And femoral puncture, again, it is not although frequently used, some people do it when there are no other options. But there will be situations when you run out of all these options, and all your arm and forearm vessels are not good enough for AV fistula, and most of the central veins are all used previously and thrombosed or stenosed. Then one option which we all knew was there for a long time, but we have never seen somebody doing it, nor witnessed any time before. So today, Dr. Sanjay will be demonstrating this feed to us. But only thing is, he's getting stuck with his technical problems, and he should be ready now. And before we move, and last meeting, I was mentioning to you about the starting of the society, International Nephrology Society. It is named as Avatar India to maintain the two familiar forum Avatar. And this is the logo we have designed. I hope people like it. We had good discussion around. Girish had a lot of suggestions, but I think we wanted to be contemporary and simple, and we have chosen this to represent cooperation for interventions and in renal problems, and the colors indicating artery and vein and so on. So I think for now this has been shortlisted, and soon we'll be registering this.
Congratulations.
Congratulations. Beautiful.
Yeah,
I like
amazing.
the logo.
Very nice.
Yeah, it's good. It's really good.
Very nice logo.
All these are being designed in Tirunelveli.
Oh, it's fine. The best has come.
It comes with a Tirunelveli halwa, am I right?
And to share more experiences on translumbar puncture of IVC, I preferred calling some influential radiologists to us, and we centered on Dr. Rajendran Vivendran, who has already been with us for other meetings, and he actually gets involved in WhatsApp also. And Dr. Senguttuvan Pandian, who is the colleague of Dr. Venkatesh from Apollo. But unfortunately today he is again has been called for an emergency and he is rushing to the hospital, he and Venkatesh, so he may not join us. So we have Rajendran with us, and Dr. Suresh has been very actively involved member of our team, and he has already had 2 sessions before, and he was actually getting ready to talk on percutaneous, endovascular AVF creation, but which was actually presented by Bharat in the last meeting. And
I couldn't attend that. Sorry, I couldn't attend that. I was on call.
And so I think Girish.
Yes, sir.
Yeah. You want to, you are very familiar with Suresh, and I wanted to mention, Suresh, you are from Staines High School, and I am from Sainik School, Amaravati Nagar. Although we were different times, I remember playing basketball matches. We used to go from Amaravati to Coimbatore, Staines, and play. They were the competitors for us in the inter-district and inter-school matches of the district. And
He was
Girish,
good in cricket and hockey. That was our main thing.
so we are glad to have you here. Girish, you want to mention a few words about Suresh?
No, I think one word I would like to mention about Suresh sir is a very great human being. Before being a great interventional nephrologist, he's always warm, accommodating, and he has many accomplishments to his stride. Like many of our parent interventional nephrologists from US, he's one of the leading lights for us. So we keep frequently meeting in American Society meetings. So sir is always very encouraging and very supportive, and his accomplishments are something we look forward to do at least 20-30% of them. I think we would have achieved our role as interventional nephrologists. So he works in a very high volume center. I really look forward to hear a lot from him and guide us in future.
Okay, kidneycare@yahoo.com. Yes. Yahoo.com. Okay. Karthik.
Yes, sir.
Yeah, then Dr. Rajendran hails from Tirunelveli, and the Tirunelveli bond is very strong. My chief, Dr. Muthusethi, used to say when I was doing DM. So any work in the officialdom and there in the bureaucracy, if there is some officer from Tirunelveli, he will send us telling the Tirunelveli fellows have a lot of bonds. So you go and meet the secretary and so on. So he is from Tirunelveli. He finished his medical school from Tirunelveli Medical College, and he went on to go to US, had his fellowship in University of Miami, Jackson Health System, then finished his American board, and he has been there as a vascular and interventional radiologist in Boston Medical Center. And amongst his work, I find that he's very much into AV fistula and in areas where we meet, and it is appropriate that he is with us today. And as Dr. Sanjay is getting ready, I will. I had 2-3 things to mention. I had asked other people also if they have anything to share, but I'll start to fill up the gap. And before that, give me just
Did we just lose him? So the other day, I had 2 cases. And the first case was a lady. We had to pull out the lines because she had a tunnel infection and she had an abscess over one of the tunnel. And the abscess was on the left IJ. She had previous catheters on the right IJ. And I told her, I cannot see your IJs anymore. I have to go to the groin. And she was just crying and she didn't want me to do anything. She said, please, whatever you can, please avoid the groin. And then, I was just looking, and Hemant, I remember him talking about the EJ, and I have not used the EJ in so long. And I managed to get into that EJ, and I put that catheter there. After so many years, I'm putting an EJ. And then yesterday, I had a similar case again. And I got into the EJ, and I noted that the first time when I tried, I had trouble getting into the EJ because I was keeping the needle parallel to the vein. So the second time, I went perpendicular to the vein. And in first shot, I went in. So do you all who are putting EJs have any thoughts on that?
Yeah, EJs. I've been doing EJs for a very long time because the university programs, you get all these train wrecks, am I right? So yeah, I have experience putting life side. I don't know whether you know life side. I belong to the quarry period. Yeah.
Yes.
Life side. We have put one EJ this side, one EJ this side. Those kind of things. The only And
Oh.
many times I've chosen EJ as my first choice rather than using IJs in certain situations where you have people with big neck, and then when the IJ is deep, EJ is available and you can use it. It is very convenient to do it. Only thing is getting the orientation.
Hello.
And
Yes.
the other thing you have to remember is that EJ is very superficial. So when you dilate it, put the sheath, and you have to be careful that you can get bleeding, but it's easily controllable. Especially, the tunnels are not that long.
Yeah.
So I don't use the sheath. I found
So
I don't use the sheath.
As long as you have, you can use it without the sheath. Yes.
Yeah, I found it as the easiest without the sheath.
And the only problem with EJs you have to remember is, the EJ crosses, it crosses the junction of the, sometimes it has to take that curve on the edge of the subclavian vein, and you get stenosis there on the long run. That's the only thing you have to remember. Otherwise, EJ is amazing and it is underutilized. Yeah, you can use.
So you suggest I use it as the first way?
People you can save the IJs in select. I've been using that for. I was counting the other day. I've finished actually about 279 EJ procedures, EJ catheters from 2000 from my time in St. Louis University to now. And now every week, 1 or 2 procedures in EJ I do, putting catheters. So
I want to do that now.
Yeah.
Do more EJs than IJs, because we do the IJs easy, but the EJ is your skill. Test your skill.
The thing is the orientation with the probe.
Sir, can you hear me now?
Yes, sir. We can hear you, Sanjay, sir.
Okay, good. Sorry for the delay. There was a lot of connection problems.
Okay. So can you share your slides?
Yeah, I'll share, sir, now.
I'll stop sharing.
Yeah.
God save the day.
So you can see the screen?
Yes, sir.
Yes.
Okay. So,
sir, 1 second, sir. So sorry to interrupt. Sir, can you please put off your video? I think some bandwidth problem with your internet. So if you switch off your video, then it will be easy for you, sir.
Yes, sir.
Now is it visible?
Yeah. It's fine.
Okay, sir. I'm very sorry for this delay which has happened. And,
no, sir, we had a good discussion.
I know. I could hear you all. So let me start. See, I started doing first of all, I thank everyone who has waited very patiently on a weekend. And particularly Dr. Bala, I'm very thankful to you that you gave me an opportunity to be on this forum and discuss how I started doing this translumbar. Not an easy procedure, but it was a necessity for my patient that I did it. So I started doing it almost 8 years back, and the number of cases that you get is very less. Because usually the patient is sent towards the very late stage and hardly people know that someone is doing it. So just to give a brief introduction, there has been a higher incidence of conventional access failure. Now, there are multiple reasons for this. It may be because, the dialysis availability is much more now in the cities or even in the periphery. So more and more older dialysis population are also coming in. There is a higher incidence of diabetes. As you know, any center will have incidence of around 40 to 50%. The late referral to nephrologist so that it gets delayed for creation of the fistula is always there. When we use the temporary catheters, the catheter-related infections are common. And we have seen that over last few years or last decade, the dialysis population tend to live for a longer duration of time. So we tend to get these problems of access. And even though I have been practicing for 18 years, still the number of patients whom we start with AV fistula as the first axis is less than 10% in my own situation. It is pathetic. I think we all need to work over this. And as you know, the government has been supporting free dialysis throughout the country now. So more and more patients are on dialysis. And, many of these peripheral centers, the nephrologists are not there to take care of them. So the fistula problems or the access problems happens. Now, what are the indications for putting in the IVC? So if you see, if there is a failure of the all conventional access, then the need arises. There has been situations where we have seen just thrombosis of the SVC, the stenosis of the central vein, or particularly not in our case, but of course in the Western population, when there is a transit for a transplant, when there is a failed upper limb accesses, then a translumbar tends to be a better option. There has been few non-dialysis indications like stem cell harvesting for bone marrow transplantation, for chemotherapy, for TPN and long-term antibiotic therapy also it has been used. And the first time the catheterization which was done, it was basically to induce the TPN in these patients. So how can we approach the inferior vena cava? You know, it's a large vein. We are scared. What will happen? The chances of bleeding and all. So if you look at the, the safe approach for that, it is transfemoral. Transfemoral, again, it is just like a femoral, how you put the femoral catheter. Only thing is, catheter is long, and through transfemoral, you put it in the IVC or into the right atrium if the catheter is long. And again, this will not have a value if already the femoral veins are thrombosed, where you have used the femoral veins for the acute dialysis, or when you want to preserve the femoral and iliac veins for transplantation. You can have a transhepatic approach, and when you do transhepatic approach, the risks are little higher, the bleeding risks are high. So best among these three is to go for a translumbar to have a better longevity of the kidney and to reduce the risks. Now, what are the advantages? Why we should choose a translumbar rather than transhepatic? One is you are going to preserve the femoral and iliac veins which are intact if you want to plan a transplant in the future. The less risk for DVT. DVT risk is less because IVC is large and the catheter is freely present in the IVC, or you put it directly into the right atrium. And the flow in the IVC is good, so the chances of thrombosis is, and getting a thrombosis in the vein is less. The risk of infection is less. As you see in the femoral region, it is close to the genitalia, the infection risks are high. If you see the catheter insertion side to the exit side, it is somewhere around the waistline. So the waistline, if you see, it is more, hygienic compared to the neckline and the line which you put in the femoral region. So the infection chances are much less. Catheter migration, catheter break and fractures are less because the stress on the catheter is less. Even if the patient is squatting, the position where it comes out, the strain on the catheter is less. There is no curves involved, major curves involved in that. And if you take any extra care to be taken for the catheter, it is not like how you do for the regular catheters. The care is the similar, and it doesn't require any prophylaxis for thrombosis. As I said, the vein is large and the flow is good. So it doesn't require any prophylaxis for thrombosis. Now, originally described by Kenny et al. Way back in 1985, the technique was first described by him, and as I told you, it was for putting in the TPN for the patient who was sick. Now, the position that is used is a prone position. We do it in a local anesthesia, or you can do it under short sedation. The only catheter kit which is available in India is from Medcom. It is called 55 centimeter TLC kit. That is a translumbar catheter kit. Now, guidance, when I started for the first time, I did it using a CT. CT, but what happens is CT is laborious. You move a needle a little, you come out of the room, you do the scan, and then you have to reposition. You have to do multiple, entry into the CT room and into the console room. It becomes tedious. And, the exposure to radiation is much higher. So off late, I have started using CR if it is with a DSA, or I use it in the cath lab. Ultrasound guidance, I have not been able to do because it is very difficult to spot the IVC and then look at the needle which is going into the IVC, because majority of the patients are obese. So to get that window is very difficult with an ultrasound. Now this is the catheter kit which is available. Now how different is it? There are catheter kits which are 55 centimeters used for femoral, but same catheter kit cannot be used. That is because the introducer needle has to travel a longer distance in this translumbar to puncture the IVC. So the length of the needle is usually 20 centimeter. The peel away sheath has to be 20 centimeter. If you are not using the peel away sheath, then your dilators has to be 20 centimeter at least, so that you reach the IVC and you have created that path for the catheter to pass in. Now, to just give you a diagram of what I do, you see, you put the patient in the prone position, you take the highest point of the iliac crest, which is marked by the scissor tip there. And, once you mark that, now that is the point of entry of your needle. You start giving local, you have to go very deep. So you have to use the introducer needle. Unfortunately, the introducer needle has a trocar and a cannula. So the trocar and cannula, you go little deep, you have to remove the needle from that and give an injection, reintroduce, goes still deep. It is little laborious. But that is the only way we can do, because that is the only needle which is available. So once you go, the direction of the needle is very important. The direction of the needle should be 45 degrees. Now you create an axis. See, there is an axis which runs parallel to the midpoint of the spine, and there is an axis which runs through the level of the iliac crest. Now you create this X and Y axis, and your needle should be directed 45 degrees to the medial and to the upper end. I hope you understand. Now this, if you see, this is the angle I'm talking about. This is the angle which is 45 degree. And when it reaches the cranium, this is the angle I'm talking about, which is 45 degree. That is 45 degree medially and 45 degree cranially. Now, most important thing what we have to remember is, you cannot cross the midline of the spine. See, if you have a patient who has a femoral which you can cannulate, you can always highlight the IVC and put it in the background for your roadmap to see that you are reaching nearer to it or not. But the problem is, when I get my patients, the femorals are already gone. You cannot do anything with it. So what I do is, my idea is this angle, and I don't cross the midline, because if you cross the midline of the spine, you will hit the aorta on the opposite side. Now, other thing you have to remember is, you are putting the patient in the prone position. So once you put the patient in the prone position, the IVC falls forward.
Dr. Sanjay,
So once it falls, sir.
Can I interrupt you for a minute?
Yes, sir. Yes,
sir. This shot is AP, is it? I mean, which is left and which is right? Because it looks for a naive person.
Sir, always for translumbar, you have to go from the right. So
right.
the needle is here. This is the right side.
Yeah, because
this is the right
we are used to looking at X-rays. This is left and that is right now. So audience should not get confused.
Now,
so
what happens, this is a prone position, and you have taken the patient in his position. The image has been taken in that position. The X-ray has taken, or you can say the fluoroscope, the first image. So the where your entry point is always on the right side, because if you go to the left side, you will hit the aorta first. So the point of entry is always right. You cannot go on the left.
Yes.
Okay. So what? Sir, then what happens is, when you put the patient in the prone position, I will show the video what I have done, but here I'm trying to give you the explanation what I do. Usually the IVC falls forward. So the direction, when you are taking this 45 degree, you have to also make sure that you come anterior to the body of the vertebra and keeping it more forward. And rest is, I think, if you can track it down through the CT, well and good. If you can track it down through the CM also will not show you IVC unless you have already had a cannulated the femoral and you are highlighting it using your dye. Otherwise, this is the direction. So I have spoken about it. That most important thing is you have to avoid crossing the midline. Now, the technique is basically simple. It is only how you hit the IVC. It is the rest of the elements are similar to placement of the conventional tunnel central lines. And there is some element like if you have been doing percutaneous nephrostomy, then it is almost like guiding yourself like that or a deep drainage. Now, I'll just give you my data of 32 patients where I have done in this procedure. And these 32 patients I have done over 9 years, 9 to 10 years approximately. So not a common procedure. The last one I had done was around 7 months back. So among these 32 patients, I had 2 failed attempts. That failed attempts in the sense I could not start the procedure because the patient totally did not agree for it. I had 30 successful procedures, out of which the 2 patients died immediately after the procedure, after the catheter was put in. One of these patients was Dr. Chaco's patient. Why this happens is, I will show you the data when I say that average duration from the last dialysis that the patient gets referred for this procedure is almost 10 days. So by that time the patient comes to me, they are very severely breathless, either fluid overloaded or in severe acidosis. And you know how difficult it is to put the patient in prone position in those conditions. So in all these patients, I have taken death on table consent and then gone ahead with the procedure. So the patients are very sick when they come to me. And one patient died after 24 hours. And remember that though they come 10 days later, these access problems would have been going on for weeks, where the flow might have been 100, 150, 180, never adequate. So probably for the last 3 to 4 weeks, they would have been inadequately dialyzed. We have to remember that. Now, if I look at the demography of my patients, 60% of the patients whom I did had diabetic kidney disease. But we also have to remember that rest of the 40% were not diabetics. That means it is not exclusive that we'll find these problems only in diabetic patients. So that means a good number of patients will also be there where the problem has occurred in spite of not being a diabetic. So the age group, if you see, only one patient was below 40 years, and 40 to 60 years, around 66% of my patients were between 40 to 60 years, and around 30% were beyond 60 years. And again, it emphasizes the fact that the complications are much more common in the later age group. Now, when I looked into what was the vintage on HD prior to the translumbar catheter was put, so average was 35.8 months that the patients were on dialysis. The shortest was 21 months and the longest was 85 months before they needed a translumbar catheter. And when I then teased down to see what was the number of months the patient was on dialysis with a catheter before he went in for a fistula or a graft, so average was around 4.8 months. That means all these patients, at least 3 to 5 months, they had been on catheter dialysis before an adequate access was created. So that may be the reason that we are finding so many problems with these patients. And when I looked at the cause of the access failure, 50% had a combination of peripheral thrombosis as well as a central thrombosis. 43% had only peripheral. That means all the peripheral veins were thrombosed chronically and you could not create a fistula for them. Only central stenosis was found in 6.6% of the patients. Now, would you say, is it worth to put in a catheter in these patients? Now, one thing I want to emphasize is these patients were referred to me, they were not my own patients. And once they go back to track down that how many of them lived with the catheter for how long is little difficult. But wherever I could, where I know that these many months they were definitely on catheter and were doing well. So I've taken data from that. So if you look at that data, the average was 22 months. Of all these, 30 patients, including those 2 patients whom we lost immediately. The longest was 55 months. It gives satisfaction that patients stayed for more than 4.5 years just with one access. Now, 55% of the patients had catheter for more than 1 year, and 37% of them had it between 6 to 12 months. And good number of them, a majority of them, they died with a functioning catheter. The catheter was not lost. As I told you, they have been inadequately dialyzed for a long period of time, and they were sick when they came to me. So as such, the mortality was high in them. Now, I'm very happy to share with you the favorable outcomes. When I'm talking about the favorable outcomes, so these were the patients to whom we gave some definite outcome. For example, 3 of these patients went in for a transplant, and 7 got a very good AV fistula created, and they were back on fistula. So that means 11% of the had a transplant, almost 26% of them went on to have a fistula. That means we were able to save around 40% of them. That is 11 plus 26%, around 40% of them. Now, a few of the patients required a change of catheter. One patient required a 2 times exchange of catheter. Again, this exchange was done over a guide wire, and the reason for this exchange was there was a crack in the catheter hub on both the times, and I was not sure what was causing it, because betadine was used for the first time, and second time the spirit was used. So somehow the catheter the patient's catheter cracked after a period of around 6 months, 6 to 8 months average. And 2 of the patient had 1 catheter exchange, and 1 patient needed thrombolysis. Now, one thing I found with translumbar IVC pump cath, which I'm using for all my other cuffed catheters, is we should teach the technicians. Mainly, we talk to the senior technicians, but we forget about the junior most one who is working in the department. Even he should be taken into account and told about the large priming volume of a translumbar catheter. And usually, though the priming volume is around 6 ml, I usually tend to ask them to flush it with 10 ml, so that there is no more. The calculation of 5 ml, 6 ml, 7 ml, I don't want. It is very easy. 10 ml syringe they take, they load it, and then flush the catheter with 10 ml lock on both the sides. And I usually keep the catheter lock volume more than the priming volume. The whole idea is the tip of the catheter where the blood is supposed to stand, it gets flushed by the catheter lock volume. And heparin lock I keep in this patient 1000 units per ml. One more important thing is, whenever the patient is on cuffed permanent catheters, usually you should make sure that the patient goes for a 3 times a week dialysis, because once we change them to 2 times a week dialysis, as you know, the heparin, the half-life comes down, and usually the tendency for thrombosis is much higher. And whenever there is a CRBSI, I tend to give 1 dose of antibiotic through the ports, because I believe that the catheter inside, the protein sheath will be harboring the bacteria, and we need to take care of that. So 1 course of the one shot of the antibiotic goes through that, through the ports, both the ports. Now, this is the image of my first patient, in which I had put the catheter through the using the CT guidance. And you see the position of the catheter. Even if the patient goes to toilet in an Indian style, there is no problem with the catheter, because it is not getting bent, or there is no stress on the catheter. That is the reason the complications with these catheters are less. And this lady went on to have a fistula later. This is another lady in whom we had a catheter. The catheter remained for 2 years, and then she went on to have a transplant. Mother-in-law was worried that she did not have any other access, and she agreed to donate kidney to her. Now, possible complications I have mentioned, because we always think about the same set of complications which we see in other cuffed catheters to be with this catheter also. But I have marked those which are common in this catheter, that is thrombosis of the catheter is common, and retroperitoneal hematoma. When you are trying to cannulate the IVC, there are chances that you may have punctured or over-punctured the IVC. The retroperitoneal hematoma chances are much higher compared to other catheters that you put. The sepsis, I told you, the infection rates are less. The fibrin sheath formation is less because the IVC is large. IVC stenosis and thrombosis literally is unheard of using these catheters. And catheter fragmentation is less, and the catheter breaks are less, because the stress over the catheter is very minimal. So I'll run the video of one of the patients that I had done the catheter. Here, this patient was so breathless that I had to do the procedure in the lateral position, left lateral position. So the patient was put in the left lateral. So you might find it little difficult to orientation, but still. Now, this is the introducer needle. I will show you one by one. Now, that is the introducer needle, the 20 centimeter one. That is the thinnest of the dilators. That is a 5 French dilator. Then you have other two dilators. That is the tunneler. That is the guide wire. It usually comes with two guide wires. I'll just stop it here. Sir, usually it comes with two guide wires. The reason is you have to, it's a long catheter. The first time when you put the guide wire, you try to measure where your exit site should be. Where you introduce the needle and the exit site, and you mark it with you bend the guide wire and mark it, and you take the measurement on the catheter. So second guide wire is basically for you to pass the catheter. So that is above the highest point of the iliac crest. Now that is the introducer needle. That is the local anesthesia that we are giving. Now I'll just go back a little. Now this is where the needle has highlighted, and we have put the dye, and we could see the IVC getting highlighted there. And this is the guide wire that has gone in. Now I'm putting the first dilator through the guide wire. This is the serial dilatation, the second dilator going in. I'm creating a subcutaneous tunnel, local infiltration of that. That is creating a subcutaneous tunnel now. In the whole procedure, it is the difficult part is cannulating the IVC. Once you cannulate the IVC, it is very easy procedure. That is because the catheter doesn't take any bend anywhere. It is very smooth. I usually don't, this subcutaneous tunneling, I don't create a large tunnel. I just allow the tunneler to go in along with the catheter directly. So I don't dilate it. I don't dilate it using the artery forceps. Because doing that, it fits in very snugly. The catheter fits in very snugly. Passing the catheter through the Pilavi sheath. So that's the position of the catheter.
How long is the Pilavi?
Pardon, sir?
How long is the Pilavi sheath? Does it reach?
It will 20 centimeters, sir.
20.
It is 20 centimeters.
So it will reach
The full length
and be there inside
Yeah,
the.
it will reach the IVC. Yes, yes, sir. So, what are the contraindications for this procedure? I have not found any major contraindications except that the bleeding diathesis, if the patient has, that may be the only contraindication. Truncal obesity has been mentioned, but majority of our patients, which I have seen, the majority of them are obese, but we have to do it. So I would say there is no absolute contraindication. One thing I put in is, it is performed only in patients with no other medical options, and it is not a primary means of central venous access. I want to emphasize on that. Thank you.